Good morning and welcome to my YouTube channel Pain Free Partha. And from this series of lectures or videos will be there about questions asked in recent advances, the fourth paper of MD anesthesiology. Today's topic is Remimazolam. Now I'm going to talk a big wish to the Professor Ravi Shankar, who is the director of C-Dreams in Mahatma Gandhi Medical College, Pondicherry. Now, why we need this Remimazolam? Can we get a propofol like sedation without hypotension? Can we get a dexmet like sedation without hypotension or bradycardia? Can a benzodiazepine can be used as a TIVA drug? So that is the thought before coming into this Remimazolam. So beware of the spelling. Remimazolam is a novel ultra-short acting drug. Now you see a spelling here. Remimazolam. So novel short acting intravenous benzodiazepine. Okay. So first approved in 20. Remi plus Remimazolam. Midazolam is benzodiazepine effect and remifentanil, the concept of ester metabolism, so that it is fast acting and rapid offset. Now you see this is Remi and Midazolam. This is Remimazolam. We can have this benzodiazepine ring along with this ester. So again you see the fentanyl and remifentanil. This is ester. So because this ester moiety becomes easily metabolically changeable or metabolizable. Okay, that is the difference between Remi. If you add Remi, that is ester, because it is esterases, counteracted by esterases. Now, what is the mechanism of action? Mechanism of action is the same. GABA, chlorothiol, hyperpolarization, neurons hyperpolarized, so the patient becomes sedated and anxiolyzed. So there is an ester bond. So plasma esterases makes it into inactive metabolites and excreted in the urine. That is the advantage of Remimazolam. So the initial dose is 5 milligrams low over a period of 5 minutes, followed by every 2 to 5 minutes we can give. So because 5 milligram 1 minute, then 2.5 every 5 minutes. For ASA3, just half the dose. 2.5, 1.25. So onset is within 1 to 1 minute actually, and duration may be up to 10 to 15 minutes maximum. So usually it goes off within 5 to 7 minutes. Sometimes we need to top up with 2.5 milligrams. So if you want to use 6 milligram per kg per hour, we can use along with the remifentanil. That is an induction. So if you start with the TIVA, Remimazolam 6 milligram and 0.3 mg of kg of remifentanil, and go ahead with Remimazolam alone for maintenance. So this is Remimazolam 5 milligram over a period of 1 minute, then every 5 minutes 2.5 milligrams. At least 2 minutes must tell us any supplement dose. This is very important. Minimum 2 to 3 minutes should go. Before that, you should not give the next dose. In ASA 3, 4, yes, we can give 2.5 followed by 1.25. Remimazolam is metabolized by plasma esterases. Okay, that is the advantage. And sometimes by hepatic carboxyl esterases into inactive metabolites and excreted in the urine. Yes, there is no difference between younger and elder individuals. There is no much difference between normal renal function and end-stage renal disease. There is not much difference between normal liver function and moderate hepatic impairment. So liver damage, okay. Renal damage, okay. Young or old, okay. That is the advantage of Remimazolam. So now what are the clinical applications? Wherever we use remifentanil, wherever we use propofol, wherever we use dexmed for TIVA, that is the basic idea. Now it is procedural sedation, endoscopy, radiological, minor surgical, in ambulatory and daycare settings, because short procedure, short sedation, no post-op drowsiness, not much. Yes, we can use in the context of cardiac surgery, for example, cardiac catheterization, electrophysiological studies, colonoscopy, etc. So these are all the, if you think a little further, it is not much different from the routine TIVA indications. Yes, it is. See, Remimazolam will take 1 minute or around 40 seconds. Propofol may take only 15-20 seconds. That is the difference. Dose comparisons, even whatever the dose, it is slower than propofol. There is, if you use Remimazolam alone, there may be increased time to extubation. That biggest advantage is flumazenil reversal. We cannot have flumazenil reversal with dexmed or propofol. So we have a drug to reverse Remimazolam. Yes, after sometimes flumazenil reversal, it may go for resedation possibly. So we may need to repeat flumazenil. Now, if we want to see dexmed, it is, yes, good, sedation, analgesia, anxiolysis, alpha 2 agonist. It reduces sympathetic flow, norepinephrine release. Yes, but target sedation is earlier with mesolam than dexmed. It doesn't produce bradycardia hypotension, but it can produce respiratory depression. Remimazolam faster recovery. So, if you are very particular about sympathetic block only, we can go for dexmed. If you are not going for that, yes, we don't want sympathetic blockade. Yes, we can go for Remimazolam, which is faster recovery. Beware of a minimal respiratory compromise. But no worry about bradycardia hypotension. That is the advantage. 1 to 2, 3 minutes, maybe around 10 minutes. Yes, we can give maintenance dose every 5 to 6 minutes. Flumazenil is the biggest advantage with Remimazolam and Mezolam, but it is very slow acting. Adazolam. But it is rapid. But BP fall will occur, but the problem is no reversibility for propofol in dexmed. Remimazolam exhibits a short, stable, context-sensitive half-life. This is very important. Stopping the infusion, how much it comes down to the half of plasma level. That is context-sensitive half-life. There is 7 to 8 minutes only. Even after prolonged infusion, that is the one biggest advantage of Remimazolam for target controlled infusion. The rapid recovery profile. Whatever be the infusion duration, you have given infusion for 12 hours, you have given infusion of 4 hours. Whatever it is, it may go under 7 to 8 minutes after stopping, the plasma half-life will come down. But the problem here is 4,000 rupees maybe for the patient. So it's an ultra short acting benzodiazepine. That is the most important thing. With predictable pharmacokinetics, rapid recovery. So Remimazolam has got an ester. So that is why it is rapidly eliminated by plasma esterases. It doesn't need one renal, hepatic. It is okay there. So there is no pulse fall, there is no BP fall, there is no myocardial depression. All these things maybe with propofol and dexmed can cause sympathetic block. The biggest advantage is flumazenil reversibility. So it is going on expanding in TIFA procedural sedation, ICU, and high risk patient. Beware 5 milligrams slow IV over a period of 1 minute, followed by every 5 to 6 minutes 2.5 milligrams. It may go for 5 to 6 milligram per kg per hour with remifentanil for induction. This is the, yes, if you are ASA 3, 4, we can come down 2.5 milligrams. Thank you very much. My slides are in painfreepartha.com and the YouTube link is Pain Free Partha. Visit my YouTube link, Pain Free Partha. Thank you all. Thank you very much.